I am joined today with my colleague, Dr. Wayne Lindstrom from RI International. Greetings. My name is Dr. Eliana Ramirez. I am the director of the CARE TA Center. We are the Crisis and Recovery Enhancement Training and Technical Assistance Center in the state of California. This is the third Cafecito recording that we have had the pleasure of conducting with Dr. Lindstrom. Today's conversation is focused on facility-based crisis management and the air traffic control system from the Crisis Now model. So for just a second, I'm going to introduce Wayne, but before doing so, I just want to give some background to people who are new to watching the CARE Cafecitos. The idea of this recording originates from the experience that many of us have had during the COVID-19 pandemic who have been working remotely, that we're really missing the opportunity to have a casual conversation with a colleague over a cup of coffee or in the staff lounge area. And so these conversations are meant to be brief recordings where colleagues just talk about the major topics that are happening in crisis continuum of care and justice diversion. And these recordings are made available for folks to check out at their leisure. Perhaps they're out taking the dog on a walk, or they're listening to something while they're washing dishes. So for that reason, we are excited to have the opportunity to speak yet again with Dr. Wayne Lindstrom. Welcome, Wayne.
Thank you very much. Good to be here.
RI International, the agency that you work with, is one of the main authors on a really exciting report that SAMHSA published in this last year, National Behavioral Health Guidelines for Crisis Care, Best Practices Toolkit. We have met 2 times prior to this session, talking about different aspects of the Crisis Now model. And I wonder if you might provide kind of some of the overview that you think is most important for people to take away when they're thinking about facility-based crisis care, as well as air traffic control from that report.
Okay. There are basically 3 core components to the Crisis Now model. If we were to be talking about a crisis care continuum, it's really much broader than those 3 core components. But when the powers that be were conceptualizing the model, they were very conscious about not overwhelming people and making the model so expansive that people potentially would be stymied, in essence, and being overwhelmed and not knowing what to choose or where to start, etc. So those 3 core components begin with what we call care traffic control, which is a crisis call center hub. And these are oftentimes organized statewide. I am the former behavioral health commissioner for the state of New Mexico, and we implemented the New Mexico Crisis and Access Line for the entire state. Behavioral Health Link in Georgia is really the exemplar, the model for care traffic control, and they operate the Crisis and Access Line for the state of Georgia. And so if you think about, because the metaphor really comes from care traffic control, in assuring safety for airline flights on a minute-to-minute basis globally, there's no room for error. I read a report that said that if there was a 1% error rate and that was deemed accessible with flying, we'd have something like 350 international crashes a day, if you can imagine that. So when you think about the way we have managed or not managed the coordination of care and appropriate and meaningful care for those in behavioral health crises, we've been too willing to accept an error rate that I can't even imagine how high it is. And you know, we certainly have seen around all of the inequity that this country has become much more conscious of since everything that happened last summer. this ultimately results in the kinds of atrocities that we saw with George Floyd and continues today, even though, police are using video cams daily, et cetera. This continues to be perpetuated. So the idea is that let's learn from air traffic control, and how can we, in an analogous kind of way, use technology to assure that everybody in a behavioral health crisis ultimately gets a safe landing, so to speak. And so a key piece of that enabling technology is really GPS. So if you think about how dependent we all are, for the most part now, on cell phones, area codes are increasingly irrelevant. I live here in Santa Fe, New Mexico. My cell phone area code is 216 because my home state is Ohio. And many years ago, my first cell phone, I still have carried that number forward. I've lived other places since then as well. But when we implement 988 and we simply use area codes, that connect me to the nearest call center in Ohio, which that resource would know what the constellation of behavioral health services or other kinds of services there are in New Mexico, for example. So by virtue of having GPS technology, you're able to locate where a caller actually is. And in the model in Georgia, they dispatch mobile crisis teams from the call center. So again, using GPS technology, statewide, they can see in real time where every mobile crisis team is in the state. They know whether or not they've been activated or not. And so you have a caller from a corner in some community in rural or urban Georgia who's calling. They then decide, and about 30% of those who call will need a mobile crisis response, because the call center usually, it's more like 10% will require a mobile crisis team response, because the crisis center call center will stabilize about 90% of the people who call. So the call center can look at their GPS mapping and see where the next available mobile crisis team is and dispatch that team that's nearest and is indeed available. So GPS is a critical technology component of a crisis care traffic control hub, if you will. The second has to do with a bed registry, and Georgia requires that all of their inpatient and residential providers link electronically with the statewide crisis call center. And in that way, when the mobile crisis team is on the scene, they will need about 30% of those cases going to a higher level of care. And if you've ever tried to shop for a bed, and I don't care what jurisdiction you're in, it's a horrific task to have to deal with. And it can take literally hours. And this is one of the things that frustrates families when they're searching for a resource for treatment for a loved one. And a mobile crisis team, the crisis call center, these are crises. We don't have time to spend searching for available beds. So by virtue of having this bed registry technology in real time, they know where the nearest available bed is to where that caller has been intervened with on the part of a mobile crisis team. Not everybody needs an escalation to a higher level of care. Some need a connection with a human services organization to deal with a social determinant of health issue like food and shelter and clothing, etc., or they may need outpatient therapy. So the state of Georgia requires every outpatient provider in the state of Georgia who accepts public money integrate their appointment scheduling with the crisis call center. So if this mobile crisis team is under a bridge somewhere in Georgia, and they want that person to be seen at 8 o'clock the next morning, they go ahead and they schedule that person for 8 o'clock the next morning. Now that requires providers to change the way that they operate in an open access model as opposed to the traditional way of doing business. So in fact, there is availability for people to in fact be seen either on a walk-in basis or through scheduling by a mobile crisis team. So that in essence is what enables the crisis call center and the mobile crisis teams to be able to have meaningful care coordination. Then what we typically would do is write a phone number down on a piece of paper, hand it to somebody, and expect they're going to be able to get follow-up care. And then, you know, it takes 2 or 3 weeks for them to actually get appointment. By then, they've potentially destabilized and exacerbated, you know, what's going on with them. And then they end up in a higher level of care, which could have been avoided in the first place. So that takes us from the crisis call center to mobile crisis teams, and then to facility-based crisis services. And there's really 2 components to that. The first is what we call a crisis receiving center oftentimes, or a crisis center, et cetera. But it is most states licensed as an outpatient service. But it's not what states are typically used to, because this is an acute care setting, and most states, is the way they've traditionally built their systems, have never thought about a community-based facility providing that level of acuity. It's always been associated with a psychiatric facility or a psychiatric unit in a general hospital or a state hospital, for example. But in the Crisis Now model, it means being able to have appropriate multidisciplinary staffing so that you can operate under what we call a no wrong door approach. Operate 24/7, 365 days a year, and you take everybody who shows up. Now that tends to freak people out when they hear it the first time, because they think, oh my God, you know, how can you possibly do that? And if you take our flagship operation in Phoenix, we're now over 82% of all of our admissions are from the back of a police car. So it doesn't matter if somebody is, you know, high on methamphetamines and is extremely agitated and acting out. It doesn't matter if they have symptoms of alcoholism. Doesn't mean if they're actively psychotic or expressing harm. We will take them. So they come into a Sally Port in shackles, and we have an expression in our eye: peers first and peers last. So the first person who engages the person after the police uncuff them is a peer, because who's better at respecting where that person is? It's so we don't have it be a clinician or a nurse, etc. And a peer typically will understand what is needed to be able to de-escalate a situation, to allow a person space and time and be respectful, be engaging, etc. And we've found by doing this, I don't know how many thousands of times now, that only about 3% of those we take in require a transfer to a higher level of care. And so we don't require the police to make an assessment about who's appropriate for us. We say, just keep coming. We're going to accept everybody 100% of the time. And if somebody comes in who's got a insulin level that's potentially lethal or something, we will then arrange transport to the ED, get that medical situation stabilized, and have the ED will monitor the activity in the ED to transfer them back to us so that we can continue what it is that we started. And so in these facilities, we don't use beds. This is an outpatient service. We use recliners because as soon as you have beds, if you get licensed because of the IMD exclusion to 16 beds, once the 16th bed is full and a police car drives up with the 17th person, you have to close your doors and say no, because licensing won't allow you to accept the 17th admission. So by virtue of having recliners, there's no such restriction. If we only have 16 recliners, the 17th person shows up and we pull another one out of the closet, it's not a problem. But it's critical in this model to be able to maintain patient flow, because in order to keep the front door open, you've got to be able to have the back door open. And the back door is the next component of a facility-based crisis service, and that's a crisis stabilization facility with beds. So we can typically stabilize somebody in that facility with recliners in 7 to 10 hours on average. 50% of them will need to go into a crisis stabilization bed because they won't be sufficiently stabilized by the end of 23 hours. So that we can keep them up to 2 weeks in a crisis stabilization bed. And so by managing that client flow or patient flow, et cetera, we're able to keep the front door open and not having to say no. So basically, that's how this all functions within the Crisis Now model.
I so appreciate the way every time that I have an opportunity to hear you describe the Crisis Now model, it is so intuitive and it makes sense from a clinician's perspective. I think that you're speaking about immediately the major challenges that clinicians face, as well as clients and clients' family members in crisis. And I appreciate the way also that the Crisis Now model is written in terms of anyone, anywhere, anytime. Did I get that piece right? That there were
Absolutely.
3? And you've just described how you actually make that function. I really appreciate also that you talk about in the Crisis Now model how to communicate to the police force so that they believe in what you're saying, because they know that the emergency rooms and jails are typically the institutions that will take anyone, anywhere, anytime. So there's a shift that has to happen to get people into, to get officers to take the chance on bringing them to your facilities. Can you talk a little bit? Oh, sorry, go ahead.
If I might interject,
Please.
you know, a lot of that though for these other alternatives is a bit of an illusion, because the police will frequently talk about their frustration in what has come to be termed onboarding. If there is somebody they have brought to the ED who's acting out, they're having to stay there until the ED staff are able to triage them. Well, you know, EDs are set up for emergency medical situations, and those who have open wounds, who are bleeding, you know, et cetera, they're triaged, they get first attention. And I have a colleague, for example, who just shared very publicly in the last couple of weeks that she has a daughter, and her daughter was in a behavioral health crisis. They went to the emergency department. They waited 3 days for her daughter to be seen. So not only is that an injustice for the person who's in crisis, and emergency rooms typically are not pleasant places to be, especially if what you're needing is, you know, a stabilizing, calming, you know, environment. But if the police also have to be there, it's an inefficient, ineffective use of their time. So one of the things the police love about the Crisis Now model is that we guarantee them that we will have them back on the street in 3 to 5 minutes, not 3 to 5 hours. And on the flip side, their other alternative is to arrest the person, book them, and take them to county detention. And we don't have good outcomes there either. And we would prefer that people not get cuffed and end up in the back end of a police car, which is why 988 implementation is such a significant development. And we can touch more on that in a minute, depending on how we do on time. But the going through the arrest, booking, and detention, et cetera, is another time waster, so to speak, for law enforcement. So the fact that they have a resource, they can have it disposed of in 3 to 5 minutes, they love. And we did a study back in 2017 or 2018 at RI, and we found that just in Maricopa County, which is where Phoenix is located, 4.5 million people, we saved the equivalent of 37 full-time officer positions. So that's time that they're spending with their public safety mission on the street, as opposed to doing these other things that haven't had good outcomes.
I have conversations with you and I feel like a little bobblehead. I'm so moved by what you say here, right? I mean, you're talking about cost savings to law enforcement as well as emergency departments. You're talking about the incalculable savings of people's lives. When you're able to help people stabilize within 7 to 10 hours, the majority of people, that is astounding. Versus what you were just sharing, 3 hours of sitting in an emergency room. And as you mentioned, that's a pretty tough place to down-regulate.
Yep.
When people are experiencing behavioral health crisis, what we need is to have a place that's calm, where, as you were mentioning before, somebody is creating space, helping people to slow the central nervous system for one, and not have to be in the midst of triaging emergencies. And if we were talking about a jail, all of the things that happen in jails, we need the environment to be calm and for people to be able to get down to the basic needs. I am so moved always also by hearing you share some of the statistics that RI is finding looking at programs like in Maricopa County. I can go down that rabbit hole very happily with you, but I wonder if you might share a little bit about 988 and how that fits into this larger puzzle, please.
Well, with 988, which was designated by the FCC last July, and then there was a congressional piece of legislation back in October that gave states the authority around the implementation of 988, basically directs phone carriers in the US to do the technology changes necessary for that implementation, and to give the states the authority to levy phone surcharges to finance all of this. And so Vibrant, which is the parent organization behind the National Suicide Prevention Line, and Mental Health America drafted a set of model legislation for 988 implementation. And Vibrant has provided state planning grants to 49 of the 50 states to implement 988, which is supposed to take place July 16th of 2022. So the idea is with 988 to be able to create a crisis response system for behavioral health that's on par with the 911 emergency medical response. But instead of having law enforcement and police cars, I hear in Santa Fe, if somebody calls 911, you not only get a police car, but you also get a fire engine and you also get an EMS vehicle. So if you're suicidal at 2 o'clock in the morning and your loved one calls 911, the last thing in the world you need is to be having all of these vehicles with lights flaring and sirens going off and rushing at your door and people, with weapons, etc. So we want to take law enforcement out of the equation. And so that when somebody calls 988, they get a behavioral health clinician who attempts to stabilize and triage the situation. If necessary, deploy a mobile crisis team made up of a behavioral health clinician and a peer to respond wherever the person is, and then to be able to have these facility-based crisis services as well. And like you said earlier, it not only saves money, but it saves lives.
And it seems like when we can free up law enforcement to attend to actual law enforcement business, rather than asking them to engage in behavioral health crisis, which they're not trained necessarily over in large part to attend to behavioral health crisis. If we instead allow people who are actually trained to deal with behavioral health crisis to be those first responders, that makes so much of a difference. And I love this model of sending peers in first, because then the peer from that lived experience perspective can say, you know, what this person might need. They're attending to the situation from the perspective of the person. So it's that person first approach that makes so much of a difference in terms of immediately building a rapport, helping people to down regulate, and is a conduit in a system that everybody shows up to this work wanting to do the best by the client. And sometimes we can be thrown off if we're focused on the policies and the practices and liabilities and this kind of stuff. We lose sight of that lived experience, that person.
Well, and I think you also point out something that's critical. I think there's a misconception on the part of clinicians that crisis stabilization is treatment, and it's not. You know, when somebody enters one of our facilities, we're not about spending time diagnosing them and then developing a treatment plan and implementing it. We're really focused on understanding what is a person's baseline level of functioning look like on a typical day, and then understanding what happened that precipitated this crisis that took them away from that typical way of being in the world to what they're experiencing now, and intervening in a way to stabilize that precipitating event, and helping the person begin to plan for how to avoid in the future a recurrence of that. So it's a very different way of thinking about the ways that we intervene than what we would normally think of in operating in a treatment setting.
I'm struck by the elegance of the Crisis Now model, both in terms of the way that technology is being used anew, from the GPS systems to thinking about the challenges, you know, just based off of area codes on cell phones these days, to this back to basics, I guess, is maybe one way to describe it, but
absolutely
really focusing on what is happening. Crisis intervention is a totally different ball of wax than what most providers who come from, whether it be social work or psychology or psychiatric nursing, most of us are not actually trained in crisis work. It's a different thing entirely.
Well, and it's really about, and you hear this in a lot of the equity discussions today, about being authentic. And, you know, our environments are places where people can be authentic, whether it's our staff or the people that are there because they're in crisis. Being authentic human beings and meaningfully engaging one another in a respectful way. And, you know, yes, we have to have the right multidisciplinary staffing and the right staffing ratio to be able to ensure that both our guests and our staff are safe. And that's what we call our patients or clients guests in our facilities. And then it's not like, you know, the old day treatment programs where in a mental health center where you sit somebody down for 6 hours in front of a TV set. We don't have our staff behind a plexiglass nursing station. They're out on the floor, and it's about meaningfully engaging people, not allowing them to isolate and to be alone. Now, we do have individuals who may be on the autism spectrum, for example, who find that that common living room environment that we engender purposefully is too much stimulation. So we also build in safe, quiet spaces as well. That doesn't mean that we keep them alone and isolated then either, but it's not the stimulating environment that being in the rest of the common space is, where we can meaningfully engage in a more subdued and quiet way with an individual. So that's ultimately how we're able to keep both our guests and our staff safe. And our goal always is zero seclusion and restraints, but we have those capabilities if absolutely we needed to that. But right now, one of the things we're piloting is called Yukuru. I wish I remember the Japanese translation, and I don't. But it's a technique and a set of padded equipment, so that if in some fact somebody is throwing punches, etc., that staff are trained on how to avoid not being harmed by virtue of that, and take more of an Aikido kind of approach to these environments, rather than pinning people on the floor. We don't have armed security guards, for example. We do hire some peers who are kind of built like football players to help us in controlling the milieu if that's necessary. But it is exactly what you said, back to basic approach about who we are as human beings and how do we meaningfully connect.
And that point of that meaningful connection, and I'm aware of our time here, I could chat with you forever, but I want to make good on our promise that these are short and sweet conversations. But so I wonder if, as the final point, when you talk about meaningful connection and being very present and authentic, that reminds me about cultural responsive practice. Mm-hmm. And that one of the benefits of being able to provide crisis support in the community is we have a higher chance of that culturally responsive engagement. And especially when we think about the peer workforce, who tend to have more diversity than when we look at our other professions, be they social work, psychology, or nursing, counseling of other sorts, that one of the great assets of the peer specialist discipline is that there is so much beautiful diversity in the workforce. And so it would seem as if part of the benefit of having your peer workforce as the first folks who are engaging people, you also might kind of automatically have more of that cultural responsiveness because there might be more diversity at that level. I wonder if you might talk at all about how Crisis Now model can kind of feed into that culturally responsive side of the spectrum.
Well, the thing that immediately occurred to me as you were talking is that by virtue of being able to have open access, immediate access, you're not putting up the barriers. I mean, so many crisis centers that operate not in the Crisis Now model have exclusionary criteria, or they require a medical clearance. So the person has to go to the emergency room, go through all the things that we talked about earlier, and then be considered for admission. And we've found, by virtue of accepting everybody, that the representation of our guests against what the representation is in the community, we have representation on the part of African Americans, Hispanics, etc., that is more than double those in our facilities than what they're represented in the community.
Wow.
So it makes a huge difference when we talk about equity and inclusion, to be able to have a accessible, immediate service that is of the kind of quality we've been talking about.
Wayne, thank you so much for this conversation. I have been talking on high about this report from SAMHSA for months now, close to a year, actually. We're almost coming up on the year anniversary of its publication. And I know for many people, they might look at a report that's more than 2 pages and think, gosh, when will I find time to carve out for my schedule to actually get into this? But I think that for anyone who's been able to watch this interview with you, the benefit is clear. There is so much to the Crisis Now model that really is a game changer, both from the perspective of clinicians and the behavioral health workforce, including peer specialists, to our institutions, be they in terms of law enforcement or emergency departments or psychiatric facilities, but especially in terms of the people who are receiving services, as you mentioned, the guests and or clients or patients. So thank you so much.
Well, thank you. And if folks aren't up to reading that SAMHSA toolkit, please go to crisisnow.com, which is hosted by the National Association of State Mental Health Program Directors. And you can watch videos about all this, not have to worry about so much reading.
Thank you so much, Wayne. This is outstanding. And we will include those links with the recording as well. So again, thank you so much for your work and your leadership in this field. It is a huge boon to all of us and a real blessing to society.
Well,
so
thank you.
So much.
I always enjoy our encounters.